presenting the operative steps of STAPEDOTOMY with TEFLON piston processes through transcanal approach for treatment of bilateral autosclerosis. The aim of surgery is to bypass the fixed stapes footplates, restore ossicular chain mobility, improve conductive hearing loss, and preserve cochlear function. Indication of surgery are conductive hearing loss with airborne gap, normal tympanic membrane, good cochlear reserve, absent stapedial reflex, and CT temporal bone is normal. These are the indication for stapedectomy with Teflon or any type of piston. Contraindications are only hearing ear, active ear infection, poor speech discrimination, severe SN loss are the contraindication. Surgical steps are: first step is preparation or infiltration in four quadrant of external auditory canal and elevation of tympanomeatal flap. After that, you have to expose the posterior canal wall annulus and you have to drill to expose the stapedial area. And this tympanomeatal flap should be elevated from 6 to 12 o'clock position. And you have to take care of cauda tympani, incus malleus, stapes superstructure or facial nerve prominence during this removal of bone hump, the posterior superior bone hump removal. After that, you have to assess the ossicular mobility. You have to check for individual malleus, incus or stapes mobility and confirm the diagnosis of your stapes footplate is fixed, that is autosclerosis. Then after complete exposure of this scutum area, and you have to clearly visualize the long process of incus, stapedius, tendon, stapes crura and footplate. After that, you remove the stapes superstructure. After removing this stapes superstructure, you have to do the fenestration, and after proper fenestration, you have to keep the piston. So during this putting the piston, you have to take care of length. Most of the piston size or we are using is about 4.5 mm prosthesis, and you can do fenestration of footplate by manual perforator, micro drill, laser can be used, and diameter of this fenestra is approximately 0.4 to 0.8 mm, and this piston placement should be proper and you have to crimp the prosthesis properly so that it will fixed, and excessive crimping may cause incus necrosis and loose crimping may cause prosthesis displacement. And after putting this piston, you can do fat, vein graft, blood clot or connective tissue sealing of this fenestra and check for perilymph leak, or you have to check the stabilization of this prosthesis. After piston crimping, you can do put some gel or connective tissue around the fenestra. After that, repositioning of tympanometer flap should be done. Post-operative care are avoid nose blowing, avoid heavy lifting, keep ear dry. Antibiotics and analgesics should be given to 10 to 15 days. You can add steroid for 10 to 15 days if there is vertigo or any symptom of tinnitus. You can add steroids. Audiometry after 4 to 6 weeks. Complications of this surgery are intraoperative complication are floating footplate, perilymph gusher, cauda tympani injury, incus dislocation, and facial nerve injury are the intraoperative complication. Post-operative complication are vertigo, SNHL, prosthesis displacement, persistent perforation, and dysgeusia. Advantage of stapedotomy over stapedectomy. In stapedotomy, there is smaller fenestra, less inner ear trauma, better hearing outcome, less vertigo, and lower risk of SNHL. In conclusion, stapedotomy with Teflon piston via transcanal approach is a precise microsurgical procedure for otosclerosis with excellent hearing outcomes when meticulous surgical technique and atraumatic handling are maintained. In this case, there is obliterative type of oval window is seen. Completely obliterate the oval window by the otosclerotic foci. There are five type of stapedial fixation in according to the foot plate area. First is antifocus, that is most common at fistula antifenestrum foci are fixation. Second is the posterior focus, lesion is spreading from posterior oval window to annular ligament. Third one is circumferential, lesion flows across the ligament totally obliterating the annular ligament. Fourth one is biscuit type, lesion replacing entire foot plate but no involvement of annular ligament leading to solid foot plate. And last one is obliterative.